Cardiovascular disease. This is Jack Brook from Columbia Gorge Community College. As you know, cardiovascular disease has the highest death rates of any health-related illness. So in this session, what I'd like to do is talk about nutrition's role in increasing or decreasing the risk of cardiovascular disease. Just for information's sake, by definition, cardiovascular disease is a disease of the heart and or the circulatory system. The main problem is a lack of blood flow through the arteries that feed the heart cells, so the coronary arteries that are taking nutrition and nutrients and oxygen and so forth to the heart muscle. So as a result, coronary heart disease would be when you don't get enough oxygen to these heart muscle cells, and then they would die, and then that would result in a heart attack in one part of your heart. As far as prevalence, looking at statistics from 2002, 29% of all U.S. deaths, 23% in Oregon. So it's a very high percentage in as far as healthcare is concerned. Costs are pretty astronomical, $258 billion per year, mainly because of heroic means and not necessarily preventative means. So because of healthcare costs, surgeries, medications, those kinds of things, you're going to have a high cost with that. What our goal is to see what we can do to prevent cardiovascular disease and maybe reduce those costs over time. The main issue as far as nutrition is concerned in heart disease would be high cholesterol, referred to as hypercholesterolemia, hyper meaning high, cholesterol meaning cholesterol, and emia meaning in the blood. So high levels of cholesterol in the blood, and mainly that relates to high LDL numbers. If you remember from our lipoprotein discussion, LDLs have a high percentage of cholesterol. And the risk of high cholesterol and the risk of high LDLs would be the potential of atherosclerosis, which is buildup of plaque in the arteries, mainly looking at the coronary arteries. But all of your arteries can be affected, and the result would be a narrowing of the openings in the arteries, which would decrease the amount of blood flow. And if you look at atherosclerosis, what you can see here is the plaque buildup, and here would be the opening, and as the plaque gets bigger and bigger, it just closes that opening and makes it smaller and smaller and smaller. So that's going to be the issue. What causes hypercholesterolemia? There's lots of factors that can affect that. As far as diet is concerned, eating cholesterol could be an issue. It's not the biggest issue, however. The studies that I've read say that increasing cholesterol, if you everything stayed the same, but you only increase cholesterol, it's only going to have about a 4% increase in cholesterol numbers. That, as we're going to see, saturated fat is going to be a big player in hypercholesterolemia. We're going to see that saturated fat is actually going to have the ability to increase blood levels of LDLs, as well as trans fats should also maybe be on there. Total calories, we're going to be able to show that total calories can increase LDL numbers. We talked about that a little bit with our lipoprotein discussion, where we said that eating carbohydrates or proteins or fat, all those are going to go through the bloodstream, eventually get to the liver. The liver, if the carbohydrates or proteins aren't needed, they will convert those into fat, and mainly the triglycerides. and then the liver will make a VLDL to get rid of those. And as we discussed, the VLDL could eventually, through the IDL, become an LDL, therefore increasing the amount of cholesterol in your blood. When we talked about fiber, we talked about the ability of soluble fiber to bind onto cholesterol, dietary cholesterol, so that would be in your intestinal tract, and take it out through your waste. So that could potentially decrease the amount of cholesterol absorbed in your body. So those would be dietary issues, and we'll talk a little bit more about those as we go through. Absorption rates, just like anything else, human beings vary in the amount of cholesterol, the amount of food, and things that they absorb. So there are some people who don't absorb as much cholesterol as others, and they're not as affected by saturated fat and that kind of thing. So it just depends on who you are and your genetics as to your absorption rate, but that can have a factor. Endogenous synthesis basically means that the liver can make cholesterol. And so we'll show in as we go through this session how the liver can make, what are the process that the liver can make cholesterol if needed. And actually 80% of the cholesterol that your body has, the liver makes. So dietary issues may be very minor, and what we'll see in some cases potentially diet may not have an effect on your cholesterol levels because of certain conditions as we go through. But if we're strictly looking at dietary factors and nutrition, specifically saturated fats and trans fatty acids, the amount of calories that you eat, total food that you eat, and soluble fiber, those three things would be critical things that we need to look at. And we'll take a look at some of those as we go through. I wanted to introduce metabolic syndrome. This is a condition that can affect not only heart disease, but also diabetes. And you may see this in your healthcare career, or if you go to get a health screen, physical, they may talk to you about metabolic syndrome. And so these are some of the conditions that could lead to a diagnosis of metabolic syndrome. Abdominal obesity basically is that visceral obesity or that fat accumulation underneath the muscles of the stomach around the intestinal area, in that as we saw with diabetes, can increase risk of type 2 diabetes. And so increase of that abdominal obesity. And we'll talk more about that. We'll have a session on obesity, and we'll talk a little bit more about that. Dyslipidemia, dys just means bad, so bad lipids in the blood. So elevated triglycerides, they're watching triglycerides a lot more carefully now than they used to. We talked a little about in the lipoprotein section the small LDL particles, and then low HDLs. So those would all be considered to be bad blood levels of lipid types. High blood pressure and insulin resistance, and that could be indicated by hyperinsulinemia and hyperglycemia kind of things. So I think the rule of thumb is any three of these in combination could lead to a diagnosis of metabolic syndrome. And metabolic syndrome has been shown to be just as bad as just high LDL numbers. A lot of us focused strictly on the LDL numbers, but even if your LDL numbers are low, if you have three of these conditions, then you could be diagnosed with metabolic syndrome, which could be just as bad as if you had high LDL numbers and stuff. So it's a higher risk So we're starting to look at metabolic syndrome a little bit more critically nowadays. But the primary target is going to be how can we get our LDL numbers down. Our goal is to have the LDLs less than 100 milligrams per deciliter, and they keep lowering those more and more. Used to be 130 or less, and now it's below 100. And so the rule of thumb is the lower than 100 you can get, the better it is. So our goal is going to be what can nutrition do to lower our LDL cholesterol numbers. We're going to talk a little bit about how the liver is going to be able to remove cholesterol from the blood. The liver is going to be the main organ that is going to monitor LDL numbers. When we talked about lipoproteins, we talked about the LDLs have the ApoB100 identification marker, which would be indicated by the protein here in the pink. And then the receptors on the plasma membrane of the liver are going to have B100 receptors. But also your other cells are going to have B100 receptors. As we talked about, the LDL's job is to deliver cholesterol to the cells. And so these identification markers will match up with the receptors, and then by phagocytosis, as you can see, the membrane is starting to surround this LDL, and it's going to bring that into the cell, and then that's how cells get cholesterol. But we'll also talk about how the liver is able to do that, to utilize that to monitor LDL numbers in the blood. So I wanted to talk about the different ways that LDL is removed from the blood. And the first one is the cell receptor pathway. This would be the normal pathway to deliver cholesterol to all of your different peripheral body cells. So the LDLs would be going around the bloodstream. If cells need cholesterol, then there would be receptors that would be made, because cells can make or take away receptors per need. So if a cell is low in cholesterol and needs it, it can produce receptors, and that would then give more recruiting ability of LDLs to match up with those receptors. So the B100 identification marker matches up to those receptors, and then by phagocytosis, the body cells would take the LDLs in and then break those apart, basically just destroy the LDL but release all its contents, and then utilize the contents within to for plasma membranes or for other things that cholesterol is used for. So this would be the normal pathway that you'd want. The next pathway is called the liver receptor pathway, and this would be the pathway by which the liver is able to take LDLs out of the blood to maintain homeostasis. Or if the liver needs cholesterol on its own for some reason, it doesn't have enough, it could also do it for that. But so the liver cells will have the receptors on them, the B100 receptors, that can be made or taken away as per need to maintain the homeostasis of blood LDLs. Here is a picture of a liver cell, and as we go through this discussion of the receptor pathway, we're going to go through this cell and look at it. So this is where it would be important to have an understanding of cell biology. But if not, you may have to look some things up, but I'll try to be as clear as I possibly can of what's happening. But we're going to go through this cell, and we're going to see how the receptor pathway works, and then later on we'll talk about what things can affect the receptor pathway to cause LDLs to be high in the blood. So just, I don't want to necessarily read this slide, but just going through it, basically the idea is that if you have high LDLs in the blood, the liver can make its extra LDL receptors, and I'll show you how, and embed them into the plasma membrane. And so the more LDL receptors you have, the more recruiting power you have for LDLs, because they will match up easier. So the increased number of B100 receptors will recruit more LDLs, so the LDLs will match up to the receptor, so the B100 identification marker will match up to the B100 receptor. The liver cell will surround the LDL with its plasma membrane by phagocytosis. It will bring the LDL into the cell, into the cytoplasm of the cell. And then one of the jobs of the lysosome is the lysosome has digestive enzymes in it. The lysosome will fuse with the vesicle. It's called a vesicle when it's brought into the cell. It will digest those contents. It will de-esterify the cholesterol. So we talked a little bit about that in the lipoprotein section, is that when cholesterol is stored or it's being transported through a lipoprotein, it has a fatty acid attached to it, and that's called esterified cholesterol. And when you take that fatty acid off, which is de-esterifying, then it becomes free cholesterol. We also mentioned that esterified cholesterol is not active. It can't be used to make anything, but free cholesterol is active. You're able to make things out of it. So once we get the free cholesterol and the contents of the LDL are usable. So let's go through that with a picture. So first of all, we have high blood LDLs. And when we have high blood LDLs, you'll notice that we have LDL receptors embedded into the plasma membrane. So if we have high LDLs, the liver cell can make these receptors. You can see it's going through a process here of making those receptors, and we can start recruiting these LDLs. Once the LDLs attach to the receptor, then you're going to go through phagocytosis. It's going to bring it's going to become a vesicle, as you see, and then the lysosome is going to attach, and it is going to start breaking down and digesting the contents of the LDL and break the LDL apart. And as you can see, one of the things that's happening is that we can release the amino acids that are within the proteins there. But also, you'll notice that these have little tails on them. Those little tails indicate esterification. So the little tail is the fatty acid that's attached to the cholesterol. Well, what you notice next is that we have de-esterified the cholesterol. We have taken the little tails off. And so this activates the cholesterol to be used, and so now we can use it to make cell membranes, hormones, bile acids. So we can make a lot of things from the activated cholesterol. Okay, but a problem becomes when the free cholesterol accumulates to very high levels. And so the liver has to do something with that free cholesterol. And three main things that can happen when you have a high free cholesterol number. So for example, the liver cell's taking in a lot of LDLs because your LDLs are high. Then it needs to do something with the cholesterol that is being accumulated. So there's three things that's going to happen. Number one is there's an enzyme that's called HMG-CoA reductase that is gives the liver cell its ability to make cholesterol. Well, if you have high cholesterol, it makes no sense for the liver to have to make any. So basically, the activity of HMG-CoA reductase is going to be inhibited, so the liver cell will not make any more of its own cholesterol. We're going to talk about the ACAT system. The ACAT enzyme system is a complex of enzymes that are activated, and their function is going to be to esterify the free cholesterol for storage. And so we can get rid and reduce the amount of free cholesterol by esterifying it, putting it into a vesicle and storing it. Either the liver can store it for later use, or it can store it and then put it into a VLDL to get rid of it. Okay, and then if we have high free cholesterol, the idea, if the liver cell had a brain and could think, it would say, well, it makes no sense if I have high free cholesterol to keep continuing bringing in LDLs, because if I continue bringing in LDLs, then I'm going to just continue adding to the free cholesterol level. So what I need to do is stop bringing in LDLs. So the LDLs is manufacturer is going to be suppressed. You're going to be actually taking receptors away from the plasma membrane so that you will not bring in LDLs. So, what this is saying then is that the LDL uptake will reduce and LDL levels will not be reduced. LDL numbers will stay high. Okay, so we'll talk about how these things can be affected as we go through, but let's go a picture of what I just talked about. So we have our free cholesterol, and what you notice is that if we get an oversupply of that free cholesterol, there are going to be three things that are going to happen. Number one is that, and you notice it inhibits the synthesis of cholesterol, which means this HMG-CoA reductase is going to be non-functional, going to inhibit that enzyme from being able to work. Therefore, the liver cell would not make any more cholesterol because it doesn't need any. Number two is you're going to activate what's called the ACAT system. And as you notice, the ACAT system is going to take these free cholesterols, it's going to add the fatty acid to it. As you notice, these have little tails on them. Those are fatty acids. And it's going to be able to store them. So therefore, we can reduce the amount of free cholesterol that's in there. The third thing that's going to happen is that you're going to inhibit the ability of the liver cell to make receptors. This process, as you can see, is you're making receptors and you're basically taking them up and embedding them into the plasma membrane. Well, basically that's going to be stopped. So you're going to no longer put LDL receptors in the plasma membrane, and in actuality, which this picture doesn't show, the liver cell will take them away. And you reduce the number of receptors on the plasma membrane. Therefore, you will reduce the amount of high cholesterol. The amount of LDL that's being brought in. So basically, this process will be eliminated, and therefore, you cannot take LDLs out of the blood, and so LDL numbers are going to stay high. Okay, so that's that process. All right. And we'll come back and talk about that more, about things that can encourage, a reduction of that receptor pathway. There are some factors. I just wanted to introduce familial cholesterolemia. This is a factor, genetically based factor, where an individual doesn't make enough LDL receptors. And so this would be an issue where nutrition or diet would make no difference, because they don't have the ability of their liver cells to make those receptors, and therefore their LDL numbers are always going to be high. But as we'll see, high LDLs is not a death sentence. It's just if the LDLs are oxidized, we'll talk about, is when they're a problem. So, but these would be individuals, and you may know someone who, is probably the fittest person in the world. They exercise, they eat perfectly, and their cholesterol numbers are still high. LDLs are still high. um, then that it may be a case of they are not able to make enough receptors to take LDLs out of the blood, and so they have to look at other means of trying to reduce LDL numbers, reduce saturated fats and things that would increase LDLs and stuff like that. So anyway, but there are just individuals who have high cholesterol. That's just who they are, and it could be this condition. The other thing you may have heard of, and this reflects on the receptor pathway, is Lipitor. And so I don't know if you can read, it's kind of small, but if you notice right here, it says cholesterol is a competitive inhibitor of HMG-CoA reductase. And so you will actually reduce the number of LDL receptors. You'll actually increase the number of LDL receptors in the plasma membrane, and therefore you're going to take more LDL. So the three things is you're going to inhibit the ability of the liver cell to make cholesterol. So its free cholesterol level is going to be low, and therefore the liver cell would want to make more receptors, and when it makes more receptors, that's going to cause more LDLs to be brought into the cell. Therefore you're going to reduce the amount of blood LDLs. So that's kind of how these statins work. But let me just go through it with a picture. So here this is where Lipitor works. Lipitor is going to inhibit the ability of this HMG-CoA reductase to make cholesterol. So the liver cell is being inhibited from making its own cholesterol. Well, the liver cell needs free cholesterol to make the cell membranes and steroid hormones and bile acids and those kinds of things that liver does. And so what's going to happen is you're not going to have an oversupply. You're actually going to have a low free cholesterol level. Therefore, you're going to activate the synthesis of LDL receptors. You notice up here, we're going to activate that, and we're going to start making more LDL receptors. Therefore, we're going to bring in more LDL from the blood, and therefore we're going to reduce LDL numbers in the blood. Okay, so that's how Lipitor and Zocor and simvastatin and some of those other things will work. And that's why you also need to get, they sometimes do liver, tests for liver function and tests for different things, because it is affecting the ability of liver cells to do what they normally do. But the goal is we're going to increase phagocytosis of LDLs from the blood, and we're going to reduce those numbers. So it's kind of enhancing the receptor pathway is what Lipitor is going to do. So I think it's kind of interesting to know how these kind of things work. Okay, the scavenger pathway. So the cell pathway and the receptor pathway are normal pathways, and they're what we would want to happen. What we don't want to happen is the scavenger pathway, because this is going to lead to plaque. So the scavenger pathway is where you're going to take oxidized LDL. So you kind of have to remember when we talked about oxidation, and where we took and formed a peroxide and then eventually a hydroperoxide in that, because we had a free radical. So you might want to go back to that section on lipids where we talked about that. But oxidized LDLs, or what we're going to call modified or oxidized, sometimes referred to as altered LDLs, are going to be removed by what's called the scavenger pathway, and we're going to have specific white blood cells that are called scavenger cells that are going to be able to engulf these LDLs, and eventually they're going to form plaque in the blood vessels. But the reason that these scavenger white blood cells would do that is because the oxidized LDLs are going to become similar to what you might say is a bacteria or a virus in your body. And the goal of white blood cells as part of your immune system is to take those out and remove bacteria and viruses and things like that, engulf those. And so because LDL is a foreign particle now, because it's oxidized, it's been changed, and I'll talk about how that changes occurs, is that the white blood cells think of it as a foreign particle and will remove it from the body. But the problem is that it's going to become plaque, and that's not a good thing. Okay, again, I'm not going to read this, but the idea is that remember we said the small dense LDLs are the bad LDLs. They can get through the blood vessel wall, and the idea is by a concentration dependent manner. Some of you that have had biology, if you remember diffusion, and diffusion is when you have solutes moving from an area of high concentration to an area of low concentration. This is very similar in the idea that small dense LDLs, because they can get through the blood vessel wall, will move from an area of high small dense LDL concentration to an area of low small dense LDL concentration. But the problem is, if there are free radicals or reactive oxygen species, and if you have a high concentration of those, they can actually oxidize the LDLs and modify them. And we'll see that that modification actually affects the B100 marker. That's its identification marker. So you can kind of think of the idea that if you change the identity of that marker, then the body will think of that as being something different. It will be identified as something that's foreign because its ID marker is different. And that will tag the LDL as being something foreign. So the scavenger cells, your immune system will say, I need to attack this, I need to get rid of it. So it'll engulf it, they'll become a foam cell. The foam cell eventually, as you accumulate, because scavenger cells can accumulate a lot of LDLs in a foam cell and become bigger and kind of fat kind of thing. And then eventually it can burst in the muscle area underneath the intima of the blood vessel, and you will incorporate collagen, a protein, you'll incorporate it with muscle, you'll have calcium, it will get hard, and you can form plaque there. So our goal in nutrition is to, number one, reduce our small LDLs, and number two is reduce oxidation. Because LDLs that aren't small and aren't oxidized usually aren't a problem. And this is just some pictures just showing you small dense LDLs that are able to get through into the smooth muscle underneath the lining of the blood vessel. And you can see these normal size LDLs aren't. They're just too big. So the small ones are going to get in, and eventually we're going to form plaque. And so that's kind of what we're going to discuss. So this I got from another article that basically says, kind of illustrating what I said, small LDL particles are taken up rapidly in the endothelium by concentration. They are very susceptible to free radicals, and reactive oxygen species we'll also talk about. And so the oxidation changes the ApoB100 identification marker, so it's not normal anymore. Scavengers will take it up, and then they will eventually form plaque. Okay, so kind of just reflecting what I just mentioned. Here's another illustration where we will see these small LDLs go in, become trapped in the blood vessel wall, and then they can become oxidized because of oxidative stress, which would be caused by excess free radicals. So free radicals can accumulate by what you eat, and smoking. When you smoke and you breathe in the smoke, you're breathing in free radicals, and polluted air, different things your body produces free radicals as a part of everyday metabolism. Um, and this is where we talked about phytochemicals, and we talked about how they're antioxidants that can take care of these free radicals. And then reactive oxygen species, we'll talk about those in just a second. But the idea, just look at the whole scenario, is that you will oxidize those LDLs. Eventually they'll become fully oxidized. They'll become foreign particles. The macrophages, which are the white blood cells, the scavengers, are going to engulf them and form a foam cell. Okay. So what are reactive oxygen species? Reactive oxygen species, you can come from the mitochondria, they can come from the endoplasmic reticulum. Hydrogen peroxide is an example, and you'll create kind of a free radical here that will oxidize things and oxidize lipids, and you'll have oxidation. The key is they can oxidize LDLs is the key to our issue here. I also put together just this, just again to kind of reflect that endogenous antioxidants, lipid peroxidation, LDL, formation reactive alcohol, all of these can react with lysine in the B100. So we have talked about oxidation of the fatty acids, but you can also get oxidation of amino acids. And a lysine is an amino acid that's part of the protein, the apolipoprotein B100. So the lysine can get oxidized. That's what changes the identification marker. So again, the oxidation of the lysine is going to change the identification marker, and so you will now have an oxidized LDL. Now, what are reactive oxygen species? HOCl, chloramine. So there's different things that are produced that can cause protein and lipid oxidation. So these are called reactive oxygen species. But ultimately, either one can lead to oxidation of LDLs, which can have their scavengers become present, and you will then eventually get plaque. So just a picture of scavenger cells, and we can see that the oxidated LDLs become modified. They will basically fit into, there are receptors that can identify that modified lysine, the receptor or the identification marker, the lysine that's been oxidized. They can identify that, and they will take up the modified LDL. But they will continue to take it up and eventually become a foam cell, as this indicates here. I did want to just to make sure you understood that here's the inside lining of the blood. And so here's where the blood is inside your blood vessel. And the plaque's going to form in the underneath the intima of the blood vessel. So it's not on the outside, so you can't really go in and scrape it off because it's underneath the endothelium lining that it forms. So inside the intima. But if you just follow this is the small LDLs, the modified, be engulfed by the scavenger cells, and you can see they're inside the scavenger cell, and it can just keep munching more and more of these LDLs, become bigger and bigger and fat, like a tick with blood, and become a foam cell. But then it will burst, and it will then be incorporated and become plaque. Okay, there. So that's the ultimate result of that. And then, so here is another picture of, here's the lining, and here underneath the lining is going to be where the plaque is. And you may have heard of angioplasty, where they put a balloon in here and they actually blow up the balloon. Actually, it's not doing anything but squeezing this flatter, just kind of squeezing it around. And then they may put a stent in there to make sure, because what's going to happen is this gets bigger and bigger. This opening here gets smaller and smaller and smaller. And if you go to the coronary arteries, that's not going to be good, because you can have clots and things like that. And then again, here's the picture of that cholesterol. And I mean, LDL basically ultimately was where it started. So the idea is, with high LDL numbers, you increase that concentration of LDLs, especially if they're small, in the blood vessels. And so the higher the concentration in the blood, then the more that those small LDLs are going to move by a concentration gradient into the blood vessel. And if you aren't, if you have a lot of free radicals, and you're a smoker, you're a polluted area, so you can eat free radicals. You don't eat, antioxidants. You don't eat plants for the phytochemicals that are antioxidants. You don't take enough vitamin C, vitamin E, some of those antioxidants. Then you are going to have high free radical numbers. You are going to have high reactive oxygen species. And so the risk of oxidizing those LDLs is going to be high, resulting in plaque. Now, if you have low free radicals and low reactive oxygen species, you're eating lots of plants with antioxidants and stuff, because again, there are free radicals that our body produces normally, so you can't get rid of those. But you can do things to reduce what you take in outside of that, like smoking and things. But if you get enough antioxidants, you can really reduce your risk. Because I mean, think about it, if the idea, even if the small LDLs do get into the lining of the blood vessel, but you don't have free radicals or reactive oxygen species, then you're not going to form plaque. Okay, it's only the oxidized ones that are a problem. So unoxidized LDLs are benign. Oxidized LDLs are the problem, especially the small ones. So looking at nutrition, and it's in what can nutrition do to affect LDL removal? Number one is that we need to reduce our long chain saturated fatty acids and trans fatty acids, because as we mentioned, and I'll show you this, they are going to affect the receptor pathway. And they are going to increase the risk of the scavenger pathway, because you are continuing to keep the blood levels of LDLs high, and you're continuing to have that high concentration difference that's going to cause them to move. And so there is research showing that the worst saturated fats that you can get are ones that are between 14 and 16 carbon lengths. And so we need to reduce those. And one of the food groups that's high in that would be dairy. So any dairy that's high in fat is going to be high in the 14, 16 carbon length saturated fatty acids. So cheeses, high fat cheeses, high fat milk, those kinds of things. So you need to drink your skim milk, and you need to have low fat cheeses. And that will help, and then reduce your trans fatty acids. So mainly, again, because we've talked about these, is pre-prepared foods, fast foods. Those kinds of foods are going to be high in trans fatty acids. So that would be a goal, is to try to reduce those. And here's the idea: is this is where saturated fat and trans fatty acids can be a problem, is that if you have free cholesterol, the goal is one of the goals is you want to have them become esterified. Long chain saturated fatty acids and trans fatty acids will not allow the ACAT system to work. And so you cannot esterify the free cholesterol. Therefore, if you can't change those free cholesterols into cholesterol esters, you're going to have an oversupply of cholesterol, free cholesterol. Therefore, you're going to inhibit the ability of the liver cell to make LDL receptors. Therefore, you're going to reduce intake of LDLs, and you're going to keep LDLs high in the blood. So saturated fats and trans don't cause your body to make more cholesterol or make more LDLs. What they do is reduce the ability of liver cells to take them out of your blood. Therefore, you're going to continue to have high blood LDLs. If you reduce your saturated fats, especially the long chain one, 14, 16, now beef fat they're mostly about 12 carbons. That doesn't mean they're good. That just means that the dairy fats are worse. So we need to reduce our long chain saturated fat, reduce our trans fatty acids. When we do that, we allow the ACAT system to do its job. Therefore, the liver cell can make the receptors and we can take LDLs out of the blood. So once again, saturated fatty acids and trans fatty acids do not cause your body to make more cholesterol or make more LDLs. It just reduces the ability of the liver cell to maintain homeostasis, and then that allows high LDLs in the blood. Therefore, indirectly, when you keep the concentration high in the blood, you have that concentration gradient. The small ones will move into the blood vessel walls, and then potentially you have that risk of modification. Okay, so that's why we need to reduce our saturated fats and our trans fatty acids. Monounsaturated fatty acids, these would have no effect on the receptor scavenger pathway. They have a lower risk of oxidation because they only have one double bond. The highest risk of oxidation is going to be the ones that have the most double bonds. So even though they can be oxidized, they're going to have a lower risk because they only have one. So they are considered good fatty acids. And so again, they're found in olive oil, canola oil, and that kind of thing. So as far as polyunsaturated omega-6, they do not affect LDL receptors, but they have been shown to increase scavenger activity, meaning that they encourage the scavengers to take out more. Now, there will be some oxidized LDLs that get through, and they are not taken up by the scavenger cells. But for whatever reason, I'm not sure exactly why, they have found that high omega-6 intake will increase the activity of scavenger, therefore increasing foam cells and potentially plaque. They also increase the clotting factor of the blood, so this is not considered a good thing. So you'd want to reduce those. And because they have a lot of double bonds, then the risk of oxidation is higher. So we want to reduce those between 5 and 8% is a goal. So that's why you don't see corn oil and safflower advertised much as being heart friendly anymore. You do olive and canola and that, but not those, because remember, vegetable and seed oils are high in omega-6. As far as omega-3, they don't have any effect on LDL receptors. They actually thin your blood, so you have to be careful with how much omega-3 you get. That's the concern with taking a fish oil pill supplement, is that some people, even though you want to limit it to 1 gram a day of the DHA and EPA, some people take 3 or 4, 6 pills because they think it's going to be better, and it really thins your blood. Also, you need to be careful if you're already taking blood thinners, that you be careful with how much omega-3 you take in, because they can have just an additional effect and really thin your blood. So you have to be careful with that. And for some reason, even though they're polyunsaturated, omega-3s don't seem to be a very high risk for oxidation, which is good. Anyway, goal, 1 to 2%, 500 milligrams of DHA and EPA. So again, 1 gram is what you want per day, or eating fatty fish or the fish with color about 2 times per week would be a goal. Okay, so our primary target was to reduce LDLs. Our secondary target is to also treat and look at metabolic syndrome. Some of the goals would be, and you probably heard these most of your life, but less than 200 milligrams per deciliter of cholesterol, greater than 45 milligrams for HDL, triglycerides less than 150, and blood pressure, should be pretty close to normal. As far as LDLs, I'm not sure if I mentioned it before. Yeah, I did, because you want them below 100. But you want your HDLs as high as possible. And so anyway, another goal would be to raise your HDLs. The way to raise your HDLs, because they can reverse cholesterol transport, so they can reduce the amount of cholesterol in your blood. They can actually reduce oxidation of the LDLs. We're not going to talk about inflammation. That's, a little bit more than we need to talk about, but there is some issues with inflammation that can increase risk of heart disease. Just some different things that HDLs can do. How do you raise your HDLs? Aerobic exercise is the #1 way to raise your HDLs if they're going to be raised. If you have low HDL numbers, the first priority would be not nutrition. It would be to get on an aerobic exercise program. That's what you want to do, because that has the most effect on HDLs. Losing weight can have an effect. Stop smoking can have an effect. Decrease. So there's different things. Alcohol drinks are one of the things with red wine and things like that would be to raise HDLs, but those are kind of minor in relationship to aerobic exercise. So that would be a real key. And this just gives an illustration that HDLs can actually, if you have oxidized LDLs, the HDLs can actually take them and remove them and bring them back, so they don't become part of plaque. It can actually remove them and actually change the oxidation and take them back to the liver. So the goal of HDLs is to reverse cholesterol transport and take these oxidized LDLs and take them back to the liver. And get them out of the system. Here's another illustration. Here is what we've gone through. Again, the LDLs get in, become oxidized, but HDL, you do have an enzyme that can kind of deoxidize them and get them back to normal, and so they can help prevent going that scavenger pathway. So HDLs are good cholesterol. And LDLs are considered bad cholesterol, but again, only if they are oxidized. Okay. Antioxidants, these are going to reduce free radicals. They're going to help reduce a reactive oxygen species. If you're taking supplements, vitamin C, you'd want, or if you're eating foods with them, you want 120 milligrams per day. Vitamin E, beta carotene, they don't recommend a supplement. You need to get it from food, because it has been, especially for smokers, actually increased some health problems. And then selenium is a mineral, but it's also an antioxidant. So if you want more information on this, you can go to the website for Linus Pauling Institute at Oregon State University, and you can get some more information about phytochemicals, about antioxidants, and so they do a lot of research down there. Okay. Sorry, I got an extra slide in there of this, so just ignore that. Iron supplementation, just as a last thought, there's a lot of talk about red meats and how they increase risk of heart disease and things like that. It's kind of being shown that, because red meats have the 12 carbon fatty acids, it may not be the fatty acids in them, it may be the iron that's in them, because it has been shown that in one study for sure that I've read, that men and postmenopausal women are at risk of getting too much iron and getting an iron overload, which can be cardiotoxic. And it can also stimulate free radicals and cause increased potential of oxidation of LDLs. So for men and postmenopausal women, it is recommended that you don't take an iron supplement. So what you'll see is the vitamin mineral supplements you find with men over 50 and women over 50, they won't have iron in them. So you might look at that because they're thinking maybe the red meat is the iron component, not necessarily the saturated fat component that is maybe oxidizing the LDLs or increasing that risk. Um, so this also becomes a concern because if you've read in your text, you'll find that one of the supplements for bread products is iron. So that has kind of been a small debate around whether we should take that out or not. The reason was because premenopausal women need the iron, and so it was put in those products for that. But anyway, so this is a discussion about cardiovascular disease. I hope it gave you some good information about the whys of why the recommendations are for the types of foods that you should increase or decrease for heart disease.